All right. Good afternoon, everybody. My name is Valeria Duarte. I'm one of the adult congenital cardiologists and imagers here at the Houston Methodist. Thank you for joining us today. We are trying to continue with our educational efforts in spite of everything that's going on. It's our commitment. So today we're going to talk about congenital heart disease, specifically about a general approach to moderate and high complexity defects. We're going to use Tetralogy of Fallot as an example, but the purpose of this talk is not to talk, not to review Tetralogy of Fallot itself, but to review how we approach imaging of each condition. And we can use the same framework for other defects, and we will continue to do that as the year goes on. So first, as I said, we're going to look at a general approach to imaging congenital defects, and this is from a multi-modality perspective. We're going to try to highlight the benefits of each imaging modality, and this will vary depending on what kind of defects we're looking at, and then we're going to quickly review anatomy and long-term complications just to put everything in context. Okay, you're welcome to send us our questions. So I like to start my talks with a slide like this, showing, because most of the audience today is an audience of adult imagers, cardiologists, sonographers, technicians, MRI and CT. So I like to put into perspective what is coming our way. So this pie chart shows us the congenital cardiac operations that were performed at a large pediatric hospital, Boston Children's, from 1997 to 2002, which means that grossly these kids that were operated back in that time frame are now in their 20s, and we're very likely to find them in our practice and in our labs. So one thing, we're very used to imaging septal defects, but as you can see, that represented 21% of the surgeries in that time frame, but by that hospital. And we can see that a quarter, if you look at number one, of the surgeries were surgeries for conditions like D-loop transposition, coarctation, LVOT obstruction, hypoplastic hearts. And then up to 15% were related to pulmonary pulmonary outflow or RVOT issues like the Tetralogy of Fallot. And very importantly, if you look at number 7, up to 12% were very complex operations for patients with single ventricle Fontan. So all these patients now survive, most of them survive into adulthood, the great majority, I should say, and we are very likely to find them more often in our imaging lab, so we need to have our toolkit ready for them. So these are just some tricks and key principles for the imagers, the sonographers, the technicians, the cardiologists, the fellows, on how to obtain an adequate study in a patient with congenital heart disease. Very importantly, we need to know what's the native anatomy. Okay, and that's a challenge. Sometimes these patients are lost to follow up sometimes, and then they're referred to us with a chief complaint or a diagnosis of surgery when as a child, unknown details. But sometimes speaking to the patients can help us. Sometimes they need some time to talk to their parents who were present. But it's important, any clues we can get will help us protocol our images more appropriately and be more efficient with time. Because it's very important to know that these patients take longer than patients with acquired conditions. And if we plan ahead, we're more likely to get a good study with good information and in an adequate amount of time. Especially, and this is especially important for studies like MRI that require our patients to lay down flat for a long time. And some of them cannot really tolerate it, and it's not ideal to conclude a study without getting the key information, okay? And secondly, it's very important to review the surgical history, and we will review that with an example today. We need to try to get the operative reports, and sometimes that can be very hard. If your referring physician is a congenital cardiologist from your institution, you're very likely to have find those reports summarized in the notes or scanned into your electronic medical records. So look for them. They're very important because different surgeries have different consequences, very different long-term complications, and we have to approach our imaging differently depending on those, okay? So that brings us to number 3. Know the long-term complications of each condition, and we'll review those for Tetralogy of Fallot to put them in context, and the long-term complications of the surgeries, okay? And then we need to know the strengths of each modality. And this is why conferences like this are important, where all the modalities get together and we learn about them, all of them, and what they can give us and what their limitations are. Because if a patient had a cardiac MRI and is having an echocardiogram after, probably there is something that echo can give me that but the MRI study wasn't able to provide, right? And so we need to learn how to use all these modalities together to provide our patients with more comprehensive information and our providers, our referring providers, so they can make these difficult clinical decisions that sometimes involve a third or a fourth surgery or a sternotomy. And then, very importantly, we need to use a language that providers from different backgrounds can understand. And by this I mean, in congenital heart disease, the referring provider can be an adult cardiologist or can be a pediatric cardiologist, and sometimes different things, the same things are called with different names. So we as imagers need to make sure that our reports are comprehensive and descriptive enough, and that we provide the information in languages that everybody can understand. So just to give a frame to our work, for Tetralogy of Fallot, as you all know, as we are all taught in medical school, there are 4 features that these patients present at the time of diagnosis. Right, first, a ventricular septal defect that you can see there, and then different levels, different degrees of RVOT obstruction and pulmonary stenosis, as well as an overriding aorta and right ventricular hypertrophy. Everybody remembers that. That's the native anatomy, right? Just very briefly. So what does the surgical repair involve? The surgical repair usually involves the repair of the ventricular septal defect, that you can see here, the VSD patch. I hope you can see my pointer. That's a VSD patch here, and then an RVOT augmentation. So this can vary depending on the characteristics of the native anatomy. Some patients will only have RVOT obstruction, and they will only need removal of muscular bundles and maybe an RVOT patch here, but they will spare the pulmonary valve annulus. So that's called valve sparing repair. However, Sometimes the pulmonary valve is also small and the annulus is small, so it needs to be augmented as well. And sometimes the proximal PA is also small and needs to be augmented as well. So you can see here in this patient, probably the RVOT, the pulmonary valve, and the proximal main pulmonary artery were small, hypoplastic, and there is a transannular patch here to correct that defect. Okay, this is different. Patients who have a transannular patch repair will the pulmonary valve annulus is not intact, so most of them have significant pulmonary regurgitation down the road. On the other hand, patients that only get an RVOT surgery, a valve sparing repair, for those the pulmonary valve may be very well in very good shape long term. So that's why knowing what kind of surgery this patient underwent, it's very important for us, okay? So what do we focus on in patients with tetralogy of Fallot? So the most important thing to assess is the right ventricle. It's not the only one by any means, but it's where we focus our efforts. Why? Because these patients are born with an abnormal RV, right, with right ventricular hypertrophy. Depending on when they had their surgery, when they were operated on, as nowadays they get operated on when they're around less than a year old, but you will see patients that didn't get operated on until they were 10, 15, 20, sometimes 30. You'll see patients that may have lived with a shunt, with a palliative surgery, with a VT shunt for a long term, and then got a complete repair. So the RV in this patient has been subjected to different kinds of loading conditions and for a different amount of time. The other thing, very important to keep in mind, is the pulmonary valve function for the reasons we discussed. Some patients may have pulmonary stenosis, but pulmonary regurgitation is by far the most frequent issue that we find, and we need to assess for severity and also for its impact on the RV dimensions. This will cause RV volume overload and dilation and dysfunction, and then in the long run, it will also cause LV dysfunction because of the electromechanical interaction between the LV and the RV. So RV, pulmonary valve function, LV, size and function, RVOT dimensions, and RVOT and pulmonary valve dimensions, I should say. And why this is important, especially in patients that will need a pulmonary valve replaced because of regurgitation or stenosis. Sometimes this can be done through a percutaneous approach. So we need to provide the information that to our referring providers so they know if this is even a possibility. So we need to measure what are the RVOT dimensions. Sometimes the RVOT is too big for a percutaneous valve. There are no anchors areas, and sometimes it's just too small for the available valves for adults. In addition, I should mention that we should provide information about the coronary arteries in tetralogy of Fallot, the coronary artery origins, and that's very important because for percutaneous intervention, the coronaries can get compressed. So we can send the patient to the cath lab with our interventionalist knowing whether the coronaries are at risk, right? And the most important thing we need to look for is a coronary that courses anterior to the RVOT that can be compressed if we balloon dilate that RVOT or proximal PA and stented. And lastly, we need to assess for everything that was done. So we need to look at the VSD. And we'll see all of this in pictures now. One thing that, and this is important, is not all the patients with tetralogy of Fallot are the same. Some patients were born with pulmonary stenosis, with severe pulmonary stenosis, but their MPAs and the branch PAs are normal. But we have patients that have very severe disease that don't have any pulmonary valvular tissue at all. We call these patients tetralogy of Fallot with pulmonary atresia. And even worse, there are patients that don't have a main PA at all. So in these patients, the repair is a little different. It's more than a patch or muscle bundles removal. What these patients frequently require a conduit, an RV to PA conduit, right? And they may have had the conduit when they were kids, so it's important to look for conduit stenosis as they grow. They may to have that conduit upgraded to a larger size. Okay, so let's take a step back now that you're familiar with the frame, and let's look at what tetralogy of Fallot looks like in the newborn. And apologies, these are congenital views. I always try to have images with the usual adult views, adult cardiology views, but I wanted to show you a newborn. So to help you, for those of you who are not used to looking at pictures like this, just think about them as a TEE, okay? But this is a transthoracic echocardiogram. Just the images are flipped. So firstly, and I am hoping that you can see my pointer. No, maybe not. Okay, so this image is what this image is trying to show. This is we can see the left ventricle, the right ventricle, the septum, and if we follow the septum all the way up, we can see that there is a ventricular septal defect, right? And right on top of it, we see the aortic valve that is overriding the septum, okay? So here we see two of the features that are usually described: the ventricular septal defect and the overriding aorta, unrepaired, right? So let's move on to the next picture, and you can see with color the flow across the VSD and the aortic. In the aortic valve, right? And if you pay attention, you may have seen that flow acceleration, that it's not coming from the aorta, and I will show you where it's coming from, even though you probably already guessed. So this is a parasternal long axis view, and we can see this is an image. Its focus is a little off axis just to focus on the pulmonary valve, and you can see the pulmonary valve there, bright, thickened. It looks abnormal, right? It doesn't open very well. And then you see the main PAs and the branch PAs, and I'm sure you notice that if you compare the MPA and the branch PAs to the RVOT, they look smaller, right? So this patient probably, in addition to an intervention on the pulmonic valve, is going to need some sort of intervention in the main PA and branch PAs to make them bigger. And we can confirm that by seeing flow acceleration here across the pulmonary valve and also in the main PA and branch pulmonary arteries. Okay. Just Doppler showing, confirming the high gradients across the pulmonary valve. So we have seen in this patient the overriding aorta, the VSD, the pulmonary stenosis, that we call it pulmonary stenosis, but it's the correct term would be RVOT obstruction. And then I'm showing you the feature that we were missing, that you can see in these short axis images, that there is significant right ventricular hypertrophy. Okay, so this is a patient with completely unrepaired tetralogy of Fallot. We don't see them often in our in our adult echocardiography labs, but it's important to understand the history of these patients to image them better. Okay, so let's look at pictures of an adult patient with tetralogy of Fallot. And it's a different story in many ways, not only because of the repair. So this is your usual parasternal long axis view. You see the LA, LV, and if you follow the septum, if you focus, I'll have you focus on the septum. Unfortunately, because we're doing this online, I cannot use my pointer, but I need you to follow me. So if you look at the septum and you follow it all the way to the aorta, you see how the septum thickens, and then at some point we see a bright structure, right, that goes all the way to the aortic valve that doesn't thicken. So that's my VSZ patch, right? Okay. We can also see that the aorta is not completely aligned to the LVOT, right? It's not perfectly aligned because this was an overriding aorta that we patched, and a lot of times we can see that the LVOT doesn't have a normal morphology as a result. Okay, so whenever you see that, and we also can look at the RV, it looks thicker than normal and larger than normal. So this one image is already suspicious for tetralogy of Fallot. And the reason I point all this is because sometimes you'll get these patients without a diagnosis. So it's important to recognize these features. All right, so then this is for my friends the sonographers who when we image patients with congenital heart disease in an adult echocardiography lab, we have to be compliant with our adult quality measures. But at the same time, we need to focus on the information that we need to provide. So as you can see in this picture, the RVOT, I cannot see the RV completely well. I don't see all the walls. And for that reason, in patients with tetralogy of Fallot, I always ask my sonographers to help me by getting an image of access that sacrifices the LV after you get me all the pictures showing the LV, because we did discuss that that's important, but that shows me all the walls of the right ventricle, right? It's just like in the second picture on the right of the screen. And then talking about how images complement each other, tricuspid regurgitation assessment is very important by echo, and also TR jet velocity, because it's really helpful for us to estimate the RV pressure, especially because these patients can have residual pulmonary stenosis, correct? And I should remind you that our TR jet velocity here is giving us an estimate of the RV pressure, RV systolic pressure, not PA systolic pressure, because our pulmonary valve a lot of times has a gradient across in these patients, right? But that's a very important piece of information. Let's continue. So I want you to remember those beautiful pictures in the newborn showing us the main pulmonary artery and the branch PAs. And this picture, if you're not able to see it in great detail, that's a true story. It's not the image quality. It's just that it's very hard to get these good echocardiographic images in some adults because they have had the sternotomies, and their body mass is much larger than our babies, and the pulmonary valve is more challenging to image. And in addition, it's the valve that we image the least in in our clinical practice, right? In patients with other non-congenital conditions. So you can see here that this image gives me a broad idea that there is some leaflet pulmonary valve tissue. But when you see this, don't get discouraged. You just give me as much information as you can get. If you put color on it, for example, here I can see that there is some pulmonary regurgitation. But I'm not very impressed by it, right? So you're already giving me that. I'll show you other examples of how. Oh. Okay, so this is patient number 2, just showing the same concept, the same parasternal long axis. As you can see here, these are real life pictures. Because sometimes we show the perfect pictures and then those are not the most useful ones. So we need to just try to learn to work with what we've got. So in this image, we're looking at the pulmonary valve. However, our color box is not perfectly placed to focus. It's not perfectly focused on the pulmonary valve, right? So that limits my assessment. On the other hand, if I look, I do see some flow acceleration in systole, and I see a regurgitant jet. And at first glance, I may not get very overwhelmed by it. Yeah, in this, very frequently it's called mild pulmonary regurgitation. And the reason is because severe pulmonary regurgitation, when it's wide open, there is no turbulence, there is equalization of pressures, so the flow sometimes is really short, so it's unimpressive. So a lot of times echo readers don't get impressed by this jet, but that's why a trick that I would give you is just go frame by frame. This is the same patient with the same quality of image and my color box not in the right position, but I can see that there is a robust PR jet there if I stop and go frame by frame, correct? So this is looking more like severe pulmonary regurgitation, if you ask me. And then to go further, the sonographer was kind enough to get me the Doppler images and show me the regurgitant jet here. And you can see, you're going to tell me, well, this doesn't look like my usual PR jet, my PR envelope that looks like a trapezoid. So this is a feature of severe pulmonary regurgitation, right? So there is equalization of pressures. So the PR envelope is more triangular, okay? So I had suboptimal imaging in a difficult body habitus, but in spite of that, I was able to look at suspect severe PR, go frame by frame and confirm it, and then by adding my Doppler profile, I can be more certain of what I'm looking at. And a lot of these patients may have stents or prosthetic valves or artifact that may limit the way how much we can assess them with MRI. So a lot of times echo, we need to make this diagnosis by echocardiogram only. Okay, and one tip that I ask all the sonographers is to move the baseline down so I can see the full envelope. Okay, sometimes I only get the forward flow and I'm missing this, and you can see how this is very important for me in these patients. And then this is an example number 3. So this sonographer has experience and went to many congenital lectures and gave me and the patient probably had very, very favorable windows, because you can see here how the pulmonary valve looks nice, the MPA, the branch PAs, and then the Doppler flow with the triangular shape as we discussed. So this patient also has severe PR, right? To and fro flow, very clear in this image. All right. So I just will talk about MRI, but since we were talking about pulmonary valve flow, this is how we look at it with cardiac MRI. Most of the time we look at it with in black and white, but in grayscale. But I like showing it with colors because I think it's more graphic, and for those of us that are used to looking at echocardiograms as well, it helps. So you also can see the same pattern that we just saw in echo. This is to and fro flow, blue and red, and then we can see here the pattern of the flow on the right, also to and fro, right? MRI measures the flow that goes forward and goes backward, and that's one of the ways we calculate the regurgitant fraction very accurately. So it's the gold standard to measure pulmonary regurgitation. But we get MRI. We don't get MRIs every year on these patients, depending on their symptoms. So usually the follow-up is done by echo. The initial diagnosis is done by echocardiogram. So very important to provide good images. So let's just to have a complete story of this patient that we were looking at by MRI with pulmonary regurgitation and echo and then MRI. So here is an angiogram. We're injecting in the pulmonary artery, and we can see how as I inject, as the contrast gets injected in the main PA, we can see how the right ventricle receives flow. And it's early, it's short, and also in physical exam, the PR murmur is early, short, and unimpressive. So that's why we need to know this ahead. And this patient had a percutaneously placed valve, and you can see now that there is, after injecting in the main PAs, we don't see any regurgitant flow to the right ventricle. Okay, so cardiac MRI. Cardiac MRI gives us the possibility in tetralogy flow of accurately assessing the wall motion of both ventricles, the end of systolic volume, end of diastolic volume, to calculate the stroke volume, measure the flows as we showed just in a few slides ago. So we perform cardiac MRIs very frequently in patients with congenital heart disease whenever possible. In the past, devices have been a limiting issue, but we were learning more and more to work around the devices and obtain diagnostic images, and that has been a great thing for our patients. So you can see here, this is your typical for those that do more echo, your typical 4-chamber view, and then we get short axis stacks to quantify the volumes, and here I want to show you again. I would love to have a pointer, but if you help me, if you focus in the image where I label the LV and the RV, and you look at the right ventricular wall and you follow it up, the RVOT, you can see myocardium in the inferior part, but as you go up, there is an area at the top, the RVOT, where we don't see any muscle thickening. In fact, we see dyskinetic movements, and that's a patch, and that's patch material. And even if we didn't have the surgical history, we can identify that. The patch will also have gadolinium hyperenhancement, so that's important. This is in MRI. We get the very similar views to echocardiography. This is again showing us the LVOT. This would be a 3-chamber view in echo. We see the LVOT and we see the ventricular, the patch, right? We see that crest. If we follow the septum from the apex up, we can see where where it ends, right, just by looking at thickening, and then we see where the patch starts and how the aorta, the aortic valve and the aorta are overriding the septum, and this we see the patch that doesn't thicken, of course, and that it appears to be intact. This is another picture of the RVOT, just a close-up of the one that we saw earlier, and you can see the area. You can now clearly differentiate where the myocardium ends and the patch material starts, right where I wrote RVOT. That's all patch, dyskinetic, and you can see to and fro flow across the area where the pulmonary valve should be, and there is just some pulmonary valve tissue, but we don't see a full pulmonary valve, and that's not infrequent in the patients that had a transannular patch repair. So you will see this. You just see some tissue, but not a full pulmonary valve. Okay, so we said we need to assess everything that was done. So we looked at the RVOT very closely. We can, in addition to the picture that I showed you, we should get an oblique image through that to have another view of the RVOT, and we need short axis view in cine to measure the RVOT dimensions in systole and diastole to help our interventionalists when they're asked to consider a patient for percutaneous approach. And then the other thing that they do in the repair is the VSD patch repair. I have seen many patients with the Tetralogy of Fallot. I also do this for research. And it's very infrequent to find residual VSD. It's not a frequent thing to find residual VSDs in these patients. But I've seen some, and this one in particular was significant. So you can see it here again. You see the left ventricle, the LVOT. If you follow the septum up, you see where the crest of the septum ends and where the patch is. You see the aorta clearly overriding the septum here, and you see that jet going from the LVOT to the RV, right? So that's a residual VSD in the area of the septum, and the reason I'm showing you this is because since the LVOT and the aorta are not super aligned, so this doesn't look like your usual VSD. So you need to look at them with this approach, right? And then let me show you just another view in a short axis. All right. Okay, so just we're running out of time, I think, but I don't want to end this talk without reminding you that the Tetralogy, not all patients, again, with the Tetralogy of Fallot are the same. So you will have patients that have the Tetralogy of Fallot and pulmonary atresia, and they are very different. I'm just trying to get my pointer here. So as we said, there are patients that don't have a fully developed pulmonary valve at all and may have hypoplastic MPAs, main pulmonary arteries, and some patients may not have a main pulmonary artery at all. So those are the patients that are going to end up with an RV2PA conduit, usually very anterior. You can feel the thrill. Very close to the sternum, very important, because your surgeon needs to know that if they're going to do a reduced sternotomy. And then some patients will have branch PA, hypoplastic branch PAs, like the first echo we saw, right? That the branch PAs were pretty small. So that's another thing that we should show and report are the sizes of our branch pulmonary arteries, okay? And here I put a full axial stack, but usually a stack of 3, just showing the LPA and the RPA, showing that their size is normal. And I do them in cine. I know that we can see them. We can see the size also in MRA, But with cine, we have the advantage of seeing flow acceleration. So if we detect flow acceleration, then we can also we can alert our referring provider. We can try to get a peak velocity across that area, and if we're not able to do it with the MRI appropriately, we can always do it with cath. And so always show the anatomy of the branch pulmonary arteries, especially in first studies, right? And if this is the first MRI the patient is having, and then I always ask our techs and fellows that are wonderful to get a flow in both PAs, because we need to report what percentage of the pulmonary flows goes to the right and what percentage goes to the left. And that's important and may lead to an intervention. Remember, we perform these studies every 3 to 5 years, and is irrespective of symptoms. We perform them more often and more frequently if we have worsening symptoms, but we do them for surveillance. So I need to be a detective and provide my referring physicians for everything they're surveilling for. Okay, and just to show you an example of why in MRI and in imaging we need to look at these things, this is a patient that had a tetralogy in pulmonary atresia. We can see here, we're injecting the right ventricle. We can see a conduit right behind the sternum, right? That appears unobstructed. But then if I show you this coronal view, you can see, I'm sure you agree with me if you look at it a few times, that even though there is flow up that conduit, the PAs are very abnormal, and there is very limited flow to the upper lobes of both lungs, right? In spite of, and you can see there is a stent there, but the flow to the lungs is very limited. So very important to know what surgery, what was the initial anatomy, what surgery they had, to give a focused assessment. Okay, so just to finalize, just putting it all together, in tetralogy of Fallot, we focus very much on the RV, the pulmonary valve function, the RVOT dimensions, the LV size and function, the branch PAs. That's something we just discussed, and we looked at the VSD repair, even though that doesn't give us issues frequently. So some tips to close. Information matters. Try to gather as much information about the native anatomy and the surgical reports, and obtain them before protocoling. It is worth the effort. If you don't find it in your EMR, just talk to your referring physician or talk to your patient when they come, or you can call them. Sometimes they need time to talk to their parents who were present when everything was discussed. If the anatomy looks complex or confusing, or the diagnosis doesn't make sense, remember some of our patients had surgery a long time ago when they didn't have MRI, they didn't have, the echocardiography was very limited. Remember, color Doppler started in the early 80s. So a lot of the diagnoses were done by cath or surgery. So patients who had surgery a long time ago, you need to challenge the diagnosis. You cannot just go with what is being told to you. But when you have doubts, get an axial or a coronal stack or a navigator to get a full 3D assessment of your anatomy and provide with an accurate diagnosis. Assess for frequent issues, complications, and associated defects, right? Like we discussed the coronary arteries in tetralogy flow. And with that, I'm going to close, and I'll take any questions if there are any, or otherwise I'll see you next time. Okay.